Hey guys, kind of just a brief discussion before I demonstrate some of the trial and an implant for the spinal cord stimulation. So you have to think the level of spinal cord stimulation has come, years and years and years. We started with single leads, single contacts, years and years ago, where we were doing one lead, one contact, treating really, one post-laminectomy syndrome. So in the last 10 years, even in the last 5 years, you've had an abundance of diagnoses now being treated. You've had different leads with different contacts coming out, different locations of placement, battery types. These are all sort of advances. As the technology develops and as new diagnoses are developing, you'll notice that companies are also changing the way they're sort of introducing these new technologies. So, we have a couple of different batteries here. Everything had started off with, high frequency and burst dosing, and now we're expanded to closed loop stimulation. We have fast programming from Boston Scientific. So you can see that all these various programming techniques are available because of the different type of patients that we have. The diagnosis has now been expanded for diabetic peripheral neuropathy. We're placing leads 9, 10, 11. A lot of dorsal root ganglion stimulation, which is also being done for CRPS. So these are different things to keep in mind, outside of just a spine patient. If you're an all-encompassing sort of pain management physician, you'll get, amputees, which is a big hot study right now with spinal cord stimulation and phantom limb pain. Again, CRPS for foot, or, cervical implants for arm CRPS. And then you have your classics. You have your post-laminectomy syndrome. You have your persistent radiculopathy. Sometimes after some of these laminectomies and foraminotomies, you have scar tissue developing around peripheral nerves that we can't really do anything about, or your nerves, your motor nerves running down the legs, your sensory nerves. That's where spinal cord stimulation comes in. So you have to kind of pick which technique you want to adopt. You have to pick which technology works best, where you're seeing the best outcomes. We know that SES works, and all these little trademarks and little changes that are being made in spinal cord stimulation are all for the benefit of the patient. So you have to just kind of figure out what works best. Remote programming is another big topic that's coming out in spinal cord stimulation. The delivery, iPhone use, Samsung use, technology is guiding its way where we can monitor exactly what the patients were doing. Before, in the older technology, it's, you had a old school battery that patients would get stimulation, would have to come in person, get programmed every few months or every year, as the device was in the patient longer. Now they have people in our clouds and AI use that's monitoring these patients. If there's a blip, or why did the patient turn the SES off? Is it impeding? Is there a contact that's not working? Is the battery not working? All of these different questions that patients have are slowly being answered by all the companies, and as they come out with their technologies. Including the battery types. The market is always who can create the smallest battery, or who can create the most comfortable battery. So that's another sort of discussion there. So SES, just like peripheral nerve stimulation, is still a hot field, even though the technology has been around a long time. So these are just a couple of the batteries here. This is the Evoke battery here from Saluda. So they're very big on their closed loop programming. So once the leads are in, there's some devices where motion or flexion extension of the patient can cause an increase or decrease in stimulation. With the closed loop, you're getting these ECAP readings and or the ability where the patient can maneuver without having, jolts, or, I'm sure in a lot of your practices, you'll have patients that say, yeah, when I lay down, it zaps my whole body, or when I lean forward or cough, I get, stimulation as such. And all the companies are sort of driving away or trying to get the leads to work in a way where patients don't feel that. This is another battery from Boston Scientific. This is a rechargeable battery. This is the non-rechargeable battery. You can see the size difference. Again, size for a lot of patients, if they're living in Hawaii or places where they're out more, they're looking for batteries that are a little bit smaller. But some patients where they have shoulder issues or they have rotator cuff issues, they're not able to charge the batteries. So we place one of these sort of thick credit card is what I call it, or when I tell patients, this is the one that we implant. So there's an option, you have these options of batteries, but when we do the procedure and the technique of SCS, that hasn't changed much, since it began. So I'll start, with the trial. I already kind of started a lead here, or a needle trajectory here. So generally speaking, we start a level and a half below is where our skin incision or our skin point is. So I've already kind of placed this one here, heading towards the epidural space there. So kind of guiding it there, picture. And so we're guiding it to the T12L1 space here. Picture. Picture. Just kind of making my way here. Picture. Okay, so we're going. Picture. And so we're looking for that purchase of the ligamentum flavum. Picture. Picture. So I'll bring this back to get a little bit more midline here. Picture. Picture. Okay. So we hit some os there. So we'll see if we're kind of getting into the space here. Seeing loss of resistance. So get lost there. And so again, along with the different battery types, you also have different leads here. So I kind of want to show you these wide space contacts here from the Saluda leads. So you can see how kind of wide space they are. And then in comparison, I'll show you the Boston Scientific trial leads here. So you can kind of see the difference there. A little bit more wider spaced, similar amount of contacts, but again, this is how these technologies are evolving to make sure that we get adequate coverage. We're able to trial these patients and make sure that they get good coverage of pain. Picture. 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 So we'll drive this there. Picture. So we're not quite in yet.
Dr. Gandhi, while you're playing around with that, do you want to speak to, I can see the way the bevel is inserted and the way you're using it as a backboard to drive it the direction you want to. Would you speak to that real briefly for the fellows and the people here?
Yeah.
How you use that to your advantage?
Right. So when you look at this lead, I'm just going to kind of pull the whole thing out. When you look at the needle here, if we can zoom in on that. Here we go. So when you look on the needle here, you can see a little hub here. So I'll go to a flat side, and you see how there's this part here, right there. So this is the flat side, which tells me that I'm, cutting away or switching the bevel away. And then you come to this side, and you can see this little notch that the other side doesn't have. This is the directionality that I use. That's why I do so many rotations with the needle. This directionality, or this little notch here, will tell me which direction. If I'm curving left or right, I can turn the needle one way or the other. If I need to dive, if it's a larger patient and I need the needle to dive a little bit more, I'll face it downwards towards the front of the body. Or if I feel like the patient's a little bit thinner, then to stay more superficial and stay posterior, I'll turn the notch upwards. And so this helps quite a bit, especially in patients that have bone, small spaces, more bone spurs, et cetera. So that's why you'll see me kind of fidgeting with this as I'm doing the trial itself. Picture. Picture.
The only thing I would add to that is using once you do get in the epidural space, if you are driving off to the right like he is, if your backstop is to the left, it's going to push it right. So you can make an adjustment and move the bevel so it will be more straight up. But what I wanted to encourage you there on, because I feel like sometimes we come kind of close to this, is make sure before you move your bevel, make sure you've backed your lead all the way out of the introducer. There's a theoretical possibility at that point of transecting the lead in the epidural space, and that would be something you might have to call a friend for. So just something to think about. And then you can't be my friend, right? That's right. We want to be friends.
Picture. Kind of getting this. Picture. We're just driving this lead in. Picture. Should be in there. Okay. So you want to stay as flat to the body as you can, just so your lead doesn't sort of migrate down. Okay, picture there. So you can see here, we're kind of driving the lead. You can go live here. So you can sometimes get some resistance here, so we'll turn the needles. Can we go lateral there? And picture.
Dr. Gandhi, what's your opinion about using the dummy that some of them have, if you can't get it to thread as far approximately as you want to, or cephalad as you want to go, using the dummy that's in the kit?
I mean, you can use it, but a lot of times I'm sort of just kind of finagling and trying to stay, with the actual leads. They have a guide wire too that you can use to carve out if there's some extra tissue there that you need. You go up with the CR. Picture. Picture, and you can follow me north there. Picture there. And let's go this way. Okay. Keep going. North, a little bit higher. Yeah. There you go. Okay, so now you can see this kind of going up towards the space there, and then we'll go back to AP.
That's a really good trick you just did there. I don't know if you guys picked up on that, but if you get stuck in the AP and you can't advance it, move to lateral, and then you can see exactly if you're going anterior or posterior in the space, and that'll help you direct it up.
And then you can go north there. So you can see we're kind of taking this weird trajectory, but picture. So what we can do now is with this kind of steering wheel here, it doesn't require a whole lot of turning, just enough to go left and right. So we'll take a picture. So I'm just kind of doing one of these. If you start turning it and twisting it, it doesn't change the trajectory. You just basically need to go right to left. You can go back to there. Yep. You can go live. We'll try to turn these a little bit here. So occasionally these leads are a little bit finicky when they want to turn. They turn, and sometimes you have to take the trajectory and take a little bit longer to turn there. So this one's kind of going in the lateral gutter there. So, I'll twist and kind of play with this. You can stop live there. Take a picture. So essentially, once we get the leads in place, our goal here is to get them next to each other. Picture again. A lot more resistance here. Picture. There you go. Picture. We're going up. Now you can go live. And let's go north. That way. Okay, so we have one lead here. Obviously, there's some scoliosis here that we can correct for, but essentially, I wanted to really highlight, the leads here about the spacing between the contacts. So you can see, 16 contacts there. We would place a second lead right next to it. But essentially, what we're trying to do is how much pain does a person have in the back? How much pain does a person have down the legs? How much pain do they have down to the foot? And that's how you kind of play with the placement of these leads. If you feel like the patient is mostly axial back pain, you may place the trial leads at 6, 7, 8. If they feel like you have back and legs, you may do 7, 8, 9. If you're dealing with a peripheral neuropathy patient, you may just do 9, 10, 11, to be honest. So that's how you kind of gauge where you're placing the leads here. So once the lead is placed, you can kind of pull everything out. So what I'll do is I'll kind of switch things up here and kind of show you the other device as well and think about the implant side of things. Again, you have the battery here. And essentially, you're doing the same thing. I'm going to kind of try to use the incision we already have. You can go back south. Okay, picture. Okay, so here. Okay, picture. So I'm just guiding this again to the epidural space. You can take your preference. I prefer T12L1 as an entry point for epidural entry. You can go in T1112, L12, but you sort of have a preference based on what you see on your film picture. So I'm just guiding this needle here into the epidural space picture. 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 There. Again, kind of playing with the needle, making sure that I'm getting the right direction. Yeah. So you can see that these implant leads here have 8 contacts. During the trial, you'll locate a CPS or central point of stimulation with the rep from the company, and they'll know exactly where the patient's getting the best relief. That's why these trials are 5 to 7 days, or some people do a little bit longer or shorter. But by that time, you'll know, hey, the best stimulation and best pain relief the patient received was at, let's say, contact 7 during the trial. So you'll stagger and make sure you have those contacts covered by using this lead. So you don't need as many, you don't need the 16 contacts when you actually implant, because you'll be a lot more specific in terms of where you want the stimulation. Picture. Let's go live. This one just wants to go forward. So again, I can turn the needle and try to get this to go the other way because it has a preference to go to the right. Hit live again. It's getting the same sort of bone spur there on that side. So what we can do is redirect here. So what I'll do is I'll go in from the other side if there's some resistance here. Picture. Picture. Picture again. Picture. Picture. Okay. So again, this is just, finessing the needle technique, making sure you know your loss there. And then you can drive this. Again, staying flat towards the body. You can see my angle here. It's not up and down. It's more about 30 degrees, but even the flatter you are, the better it works out here. Live. So we're going up this way. Okay. Yeah, so there's a scoliosis in this patient. That's why it looks almost like it's in the gutter. But say we kind of want to stay here. We can essentially pull out the stylet, which I did there, and then kind of also pull out the needle. There. And so when we're implanting, you have, these different anchors here. So you can put these anchors onto the lead. They click on. And this is all stuff that you can kind of work with in the lab. It's a little bit harder to see video-wise and get a tactile feel. But essentially, this here will actually sit in the pocket. You can fixate it down, click it, suture it down. And then essentially what we end up doing, again, I'm going to skip this step and leave it for the lab, but you have this device here, which is a tunneler. So what you do is you kind of bring this here, and you've created a battery pocket here too. So there will be a battery pocket for the device right here. So another incision goes across this way, and what will end up happening is this tunneler will get through to the battery pocket. You'll thread the lead through, and then you'll plug the battery in, make sure you get all green from the rep. And then, you basically close the sutures or close the incisions with either Stratafix, Dermabond, staples, all of the above, a couple of the above. And then essentially you're done. The patients can be programmed pretty quick right off the table. So they'll have incisional pain, which you kind of give them a heads up about. But in terms of their sciatic or radicular symptoms, they may have relief right away. So that's generally speaking. Again, we want to make sure that you guys get some hands-on in terms of how to do the battery pocket, making sure that you dig enough. These batteries can recharge about 1 centimeter away from the skin. So you don't need to be, if you have a non-rechargeable battery, then you can bury it as far deep as you need to. But if you have someone where they are going to recharge and the lifespan of the battery is a little bit longer for the rechargeable battery, then you want to keep it at least no more than 1 centimeter deep from the skin so that you have access for them to charge the battery. And I'll leave it at that for questions.
Thank you, Dr. Gandhi. Any questions from the audience? Okay, so there's a billion options out there, Dr. Gandhi, with lots of different companies and stuff. How does somebody who has never been involved in this start to select what's the best device for their patients, or do they use a specific device for a specific patient type, or is it better to do the same one on every patient, or how would you answer that?
So essentially what I kind of chose, there's a couple different mentalities to this. Is one, from the physician standpoint, you want one that can steer the best. You want to make sure this, every company has good data behind them on what they're good for. But essentially you want to I use kind of like, if you have a thin patient, do you pick a company that has a smaller battery? Do you have a patient, or from the physician standpoint, does one steer, and this is where you learn these things at these different courses, is do you feel like one steers better going up and down the spinal canal? Are you able to turn the device a little bit better? To be honest, it really depends. If you're first getting into spinal cord stimulation and you're trying these different devices, you'll find out what works best in terms of your technique, and then your patients are the ones that are giving you the feedback. You may do 5 Saluda trials, you may do 5 Biotronic trials, you may do 5 Boston trials and say, okay, patient feedback wise, who has gotten the most relief or the best relief, and which did I feel technique wise was the easiest to drive or easiest to utilize or do the procedure with. And that's how you'll come up with a game plan. And then you may narrow your choices to one or two companies that you use routinely.
Good. Any other questions? Can you give us an example of one CRPS patient you've treated with this and just how it worked for them?
Yeah, so there's a patient where the patient had because I work at a big orthopedic group, so I had foot surgery, had hardware placed, developed CRPS of the foot. So we essentially you could do lateral stim, you could do conventional stim, but essentially we placed the leads down at 10, 9, 10, 11, and we're able to get coverage all the way down to the foot. Now, you have people that'll do lateral stimulation. You have people who do specific DRG for L5 and S1 to get the foot. These are all techniques that kind of, come with the territory. But even just conventional stimulation, dorsal column stimulation at those lower levels, patient had great relief. Obviously we know if there's an offending factor for CRPS, like a hardware or a pin, you take it out, they'll get better most of the time. But these are patients who actually require and need the pin or the hardware placed, and they're dealing with pain continuously. A new population that's sort of coming into the practice are, cerebral palsy patients as well. They're younger, but there are a lot of those cases as well where there's a lot of foot, lower extremity symptoms, where SCS is kind of being used or trying to be used for it.
What's the youngest patient you've done an implant on?
So I had a 28-year-old gunshot victim. Right through the peripheral, not the femoral nerve, sort of the peroneal nerve down by the ankle.
Yep.
And so he was getting onto high doses of, opiates, methadone, and then we ended up implanting him conventionally, and he did really well.
Good.
So I don't put an age as obviously if someone's really young, you want to try everything else beforehand. But if they've done everything and there's really no end in sight to the pain, then you kind of use this. Especially if they have no spinal conditions or anything like that.
Good. Gavin, same question.
This is kind of a more broad question. I had a patient a long time ago who he had traumatic fracture at L1, and he had cauda equina syndrome, and he had arachnoiditis and scarring all around. He was a workers' comp patient, so we weren't able to get the stim approved. But have you guys ever seen cauda equina and how that's best treated? Looking through the literature, I didn't really see that stim is typically done for those patients.
Let's give that question to Doug.
So you can try modulation, but the real treatment for arachnoiditis is pumps. I mean, that overwhelmingly. So arachnoiditis comes from various things. It can be post-surgical, it can be traumatic, and I'm talking about cauda equina inflammation, not cauda equina syndrome,
Yep.
which is compression of the cauda equina. It's amazing that a little bit of intrathecal pain medication, opioid, just almost gets rid of the arachnoiditis immediately. So anything that you can try stimulation, but you'd always do a trial first. And if the trial is successful, okay. But if the trial is unsuccessful, which in my experience it is about half the time, then you could go on to intrathecal drug delivery, pumps.
Good indication. Okay, good. I think we're at a point where we're going to take a break. Corey, does that sound good? Okay, everybody has about a 10-minute break, so fill up on drinks and food and bathrooms.